Hello, everyone, and welcome. On behalf of Frontier Nursing University, I want to welcome you to our session today. I'm Dr. Erin Tenney. I'm one of the faculty here at Frontier. I'm a nurse midwife and the course coordinator of our Health Equity and Health Promotion course. It's my honor today to introduce Nicole Gonzalez, who is a very respected colleague of mine. She's an acquaintance, and over the years, I've followed her work, and it's really profound. I have such great respect for the work Nicole has done, and watching the transformation and the growth is just deeply inspiring. We finally got to meet in Bali at International Confederation the Midwife Conference this spring, and it's just exciting to be able to watch your work grow, Nicole. So I'm going to provide her bio and then hand it over. So thank you. We really just from the bottom of our hearts want to thank you, Nicole. I know how incredibly busy you are. Nicole is a highly sought after international speaker, and she's also a PhD student and runs a nonprofit and still has a clinical practice. You're just beyond busy and amazing, Nicole. So we really, really are so grateful for your time. Nicole Gonzalez is a Dene nurse midwife from the Navajo Nation. She is the founder and health policy director of Changing Woman Initiative, which has the mission to empower diverse Indigenous communities to protect cultural birth resiliency and the fundamental Indigenous human right to reproductive health, dignity, and justice. Nicole is internationally known as the leading Native American maternal health expert who uses her knowledge, skills, and wisdom as a nurse midwife to inform innovative changes to maternal health policy and community wellness. She presently serves as the board treasurer for the Groundswell Foundation with the years of experience in organizational development, fundraising, and leadership development. Nicole is now the CEO of Transcending Strategies, LLC, which works towards systems changes in maternal and reproductive health, personal leadership development, and Indigenous health policy reform. Thanks so much, Nicole.
Yeah, everybody. It's very nice to be here and to meet you all. I have presented some work that I was working on in the past with Frontier, and I had the pleasure of visiting your campus actually a few years ago, and so it was nice to be asked to come back. And I'm really excited to talk about this topic. As Erin's mentioned, I'm making some shifts in my work right now. And so this is really reflective of like where my mind is at with the work that I'm doing. And a lot of you know me through my foundational work through Changing Woman Initiative, which is a nonprofit I founded in 2015. And really, I like to say that I've been doing this work for about 11 years. So I started as an OB nurse, and then I saw issues in our community around how Native women were treated in childbirth, and then further realizing there isn't a lot of information about our communities that's reflected in the research. And even what's reflected there isn't always positive. So my curiosity was piqued, and then I was like, I really got to go back to school and be a midwife because I really wanted to have some, I would say some power around being able to navigate with pregnant women where they access care and how they're taken care of in a hospital. But through that process, this bigger vision of starting Changing Woman emerged. And it's a huge endeavor, right? You have all this desire and passion to improve your communities, and what are the pathways can we do that, right? Some of us do that through our advocacy work or our grassroots work, our writing, through our professional development, through our work as midwives and healthcare professionals. I just took a big piece and was like, I'm going to do this. And I haven't done a lot of speaking so much on the design of Changing Woman and the intention behind creating that. And it's interesting as I've come into my PhD program, which is about organizational leadership. I'm learning a lot about leadership and organizational design And it's really nice and reflective from my own process of like what has been created and why it's been created that way. So this is really reflective of that process, the why, the intervention, which is this nonprofit work, as I consider it an intervention, and some of the challenges I faced along the way in creating that, and some things I learned. And so really, that's really what I'm hoping to help you guys process through with me through this presentation. I call it off-roading because, like any artist or creative person, we have our skill sets that we use to draw a painting or to do some beautiful work. And, you know, you've just heard Erin talk about all my skill sets and my experience. And so I'm able to pull from those experiences to create something that is different. It is off-roading because some of this has not been done in this way. And so there's a lot of learning that happens when you are creating something new. And there's a lot of things that have to be in place with the kind of people you work with for that to happen. So this is what that we'll talk about in this presentation. I really love Abigail Eckhart's words around, I'm not historically underserved, I'm colonially oppressed and institutionally underserved. I feel like that really speaks to like these issues that we see around why certain populations have better healthcare than others. Having done some international work and looking at their social systems and how they view health and maternal health specifically, you get a real sense of like women's value in the United States it's just not there. And recently I did this presentation for the UNM program recently. And this slide I saw actually on the, what is that, Instagram. So I was like, this really makes a lot of sense. If we don't know where women are dying, where our health workforce is, where midwives are, where the gaps are, it's going to be very difficult to address the issue and get the right midwives at the table. I really took that to heart 10 years ago because I surveyed the whole communities that I'm from. I'm from New Mexico. We're located in Albuquerque. And I really looked at the big picture of like where are midwives working, what are some of the policies in place that affect our care and access, what are the challenges that we're facing on integrating culturally rooted care into our services. And so I just took a big look at everything to see what that looked like, because obviously I was designing my program to meet some of the needs in my community, but I needed to do this homework first. So just some overarching learning objectives is right, having some understanding about health disparities and how it affects the communities that we're serving. The role that health policies play when we're trying to access services and funding, and really defining this regenerative design process for change, which I finally have language to explain what I've done and how I've done it. And the understanding and importance of problem solving as part of our design. And then lastly, conceptualizing creative, innovative teams and organizational design to address complex problems. Like that's what we've done, right? The last 8 years of my work is basically these sort of things. Again, not an exam, but more of an understanding of structural racism and how that plays a role in this work. So we know that structural racism is a burden of disease and injury and violence in our communities that are preventable, but are morally highly experienced by social disadvantaged people. But there's things structurally in our design in regards to like healthcare systems, educational systems, even how we get access to skills and knowledge that make it out of reach for certain populations for various reasons. And so that's what we would consider a structural racism. So it's like intentionally keeping people away from these types of skill sets, or making it harder for them to advocate for themselves. Health disparities, we hear about this all the time in our educational systems. I've been to many conferences where they talk about this. So basically, so defined as policies and practices that exist through a whole society or organization that result in support and continued unfair advantage to some people and unfair or harmful treatment of others based on race. There's another term that I learned recently that I didn't put in my presentation, but it's called policy, what is it? Health policy disparities. I think that's what it, I'll get back to it. And then regenerative refers to a system's ability to evolve its own capacity to build and beneficial reciprocal relationships with other systems. These connected systems increase and distribute resources over time. I really just want these language words, definitions to just sit with you as I'm like going through my presentation. And really it's just like, again, backdrop thinking. So a lot of what I'm going to talk about is like why we created my organization, some of the current challenges that we're facing in our community. When I first started Changing Women, I was really seeing a need for culturally centered maternal health care for Native American people. And that was about, like I said, 8 years ago. And at the time, there was no birth center or healthcare service directed at serving Native people while integrating culturally sensitive care other than IHS. So Indian Health Services is our healthcare delivery system for Native people. And it's basically a government mandate that the tribes have in regards to how our healthcare is going to be managed. It's a very complicated history, so I'm not going to go too much into that. But at the time, that was the only option we had in regards to maternal health care. Through the years, I was really determined to start a birth center, thinking that this maternity home where people could have their babies culturally supported by Indigenous midwives was really the way we needed to go. At the time, it was a new idea, and as in the last 8 years, there's so many other organizations and programs that have popped up, seeing the same issues that I'm seeing and trying to address the issues in their community through some sort of grassroots organizing, whether it's a coalition or doula support or supportive services like lactation services. They're all trying to fill in these gaps in their community. So I want to talk on maternity care deserts. So right now, this is based off the March of Dimes report from 2022. So all of these red areas are considered maternity care deserts. So basically that means there's no a county without a hospital or birth center offering obstetric care without obstetric providers. So you can see down the center, there's a whole lot of those, and then off into Hawaii, Alaska, there's a big part of those. So 36 of the US counties designated are considered maternal health care deserts. So basically, 6.9 million women and almost 500,000 births across the US have no access or low access to a midwife, a doctor, or a hospital. And there has been actually an increase 5% in counties that have less maternity access since 2020. So if you think about your model, right, you guys are trying to train more midwives at the Frontier Nursing and what was created there by your founder. Like, it's interesting that this is how many years later, and we're still dealing with access issues to maternity care, and it's just getting worse, right? This is just a snapshot of New Mexico, and this is what our maternity care desert looks like. So like 33 of our counties are considered maternity care deserts. So all of these light areas don't have access to maternity care, or they have like low or moderate to no full access. So if you, the darker areas, that's where cities are down the center. Albuquerque is there, near the center of Santa Fe. A lot of the times, this is where healthcare is. So from 2019, we still had 33% of our counties not having a single obstetric provider, so it hasn't changed. So that's 9,674 women who live in a county without single obstetric provider. So what does that mean, right? What does that mean we don't have healthcare in our counties? New Mexico also rates 21.4% for inadequate prenatal care as compared to the US. I'm not sure what you guys is up there. It's like, but the US rate is 14.5%. So we're pretty high. And some of the common causes for women not accessing care in the first trimester are they don't know they're pregnant, they couldn't get an appointment, they don't have enough money or insurance, or they don't have an insurance card at the time of appointment. They don't have transportation. They don't want anyone to know they're pregnant, or last, the doctor's office is too far away. Our preterm rates here in New Mexico are up. So they were 9.7 and now they're 10.0%, which is up from 2011. It's not like a big rise, but it's still a rise despite all these beautiful, how would I say, advances in medicine. We're still not seeing a change in our preterm delivery rates. So just looking at like the state of midwifery. So where are midwives in New Mexico? So New Mexico has a really interesting history. We had parteras, so Spanish healers, Spanish midwives, before licensed midwives, before midwifery became licensed in our state. And basically what the Department of Health did was say, we like what you guys are doing, continue to provide birth services, just track your numbers. Here's some training on aseptic technique. So we have a mix and a blend of midwifery in New Mexico because of that. So we still have licensed midwives. We also still have our traditionally trained traditional midwives in our Native communities. We also have CPM, certified professional midwives, and then we have your nurse midwife like myself. This one is looking at like how many licensed midwives in our state. So as of 2022, which is last year's report based on New Mexico workforce, we had 8 licensed midwives leave New Mexico, and we have 3 new LMs in New Mexico. What that means, we were 5 less midwives than we used to have. Although there's like 29 licensed midwives not working in our state anymore. But if you look at the picture, you see where the midwives are, right? Bernalillo, Sandoval, Rio Arriba, Taos. Those are cities. San Juan doesn't have any licensed midwives working there. Doña Ana doesn't have any. Sierra County, these are all counties. So the areas where there's green, there's like 1 or more midwife working there. So they're actually, that's a good thing. This is our nurse midwife workforce. So we have 29 nurse midwives that left their practice in New Mexico this past year. We have 21 new nurse midwives working in our state. So what is that, like 8? We still are -8 for nurse midwifery in our state. There are 23 certified nurse midwives who are licensed in New Mexico, but are not in New Mexico practicing. Again, looking at this map, where are they working? Santa Fe, San Miguel, Bernalillo. Bernalillo is where Albuquerque is. Santa Fe is, well-known attraction. Doña Ana is down there by Las Cruces. They have a hospital. San Juan County up there, up north. There's 6 midwives working, and so they have 2 hospitals. So these are all like areas where there's hospitals, there's resources. All these yellow areas, those are rural areas. There's no hospital, there's no provider there. So if you remember the maternity care desert map that I showed you, we didn't get a good look, but in New Mexico, these yellow areas are considered maternity care deserts in New Mexico. Thinking about where the workforce is important, because if we're thinking about creating a program to serve our communities and our midwives are all working in the city or in places where there's access to care, that should tell you like where people are going for care, or like these areas that are not getting access or have people have to travel further distance, like how are they being served? So New Mexico, we have a very high average of midwives attending births. So 26.4% of births are attended by midwives. It doesn't say nurse or licensed or certified, just a midwife. The US average is 10.3%, which is we're above average. So because of our history, we've really integrated midwives into our services in our communities, because what did Department of Health say? We love what you do, keep doing it. That really makes a difference. And this is just a little picture where we have birth centers. So up here is Breath of My Heart. They are a CPM run birth center in Espanola. So Riobamba County is actually a really poor county. It's used to be the highest per cap place for drug use, so like for heroin. It's a very poor community. I believe now there's like a practice of 3 midwives. They've recently transitioned over to 2 indigenous, one's a doula, one's a midwife, who now run the organization. So they've shifted their focus to be more indigenous focused. They used to have an LGBTQ executive director, so they also really center queer individuals, and they provide service to primarily Medicaid insured folks. So they have a service model focused on serving low income people on purpose. The Santa Fe Birth Center is a CPM LM blend birth center. They're kind of struggling to keep staff, but they also are serving the Santa Fe area. I can't say that they're specifically focused on Medicaid insured or uninsured folks. I believe they're just trying to serve all people, and they have kind of a boutique style birth center. Darla Luz is a CNM only birth center in Albuquerque. It is nationally accredited. I believe there's 7 midwives that work for them. They're all nurse midwives. They don't do home births. They just do birth center births. And then there's a La Clinica in Silver City. That's a CNM practice. And then the La Tierra in El Paso, which is, even though it's Texas, it's on the border. And so they're a CPM practice. The reason I'm listing these birth centers this way is to give you a sense that every birth center has a different focus and a different service area that they're providing care. So when we think about birth centers being safe model, a healthy, normal intervention in the community, their focus isn't always equity in regards to like serving low income people. Sometimes they just want to provide another option in the community, and their focus can be a blend of payer sources and a blend of people. I can tell you, Darla Luz's Medicaid population, I believe, is like 30%, whereas Breath of My Heart, I think, is more on the like 75%. So, and that makes a difference because of how they're reimbursed for care, kind of underwriting their services so they can provide the care they want to provide. So this is a financial side of things, because whoever you're serving, you might have to underwrite services to take care of them. So on the policy side, I've traveled a lot. I've been to other countries. There's lots of recommendations being made on improving maternal health. So this one is a shadow report we submitted alongside other healthcare teams or reproductive groups last year. And basically, this was at the United Nations Committee on Elimination of Racial Discrimination in Geneva of I believe it was last August we were there. So the recommendations we made is to remove barriers to accessible, high quality, comprehensive reproductive health care, ensure that communities of color can access and provide culturally aligned services that improve maternal health, including midwifery and doula care, ensure that meaningful participation of women of color in all decision-making processes that impact their reproductive health. The positive thing is these recommendations were actually implemented. So the nice thing about the UN Committee on Elimination of Racial Discrimination is it's a treaty body. So basically, the United States has signed on to this treaty and they ratified it, so they have to enforce it. So every 5 years, they have to report back to the UN on how they enforce these recommendations. And so a lot of our repo recommendations were actually included in recommendations to the US to make these changes. Now, how does that affect what we're doing on the ground, right? That's the question. It provides the language and the support on a global scale to implement policy change that it's supported, right? This is a United Nations document. And these are the recommendations that it's making to our communities and our healthcare organizations and our midwifery organizations to make, to improve maternal health and reproductive health for our communities. So that's really what that is. Last year, I saw some other recommendations being made. So like the United States released their White House blueprint for addressing maternal health crisis. And these are just 2 of the 5 recommendations they made. So one is investing in rural maternal health care. Another is more diverse maternal health care workforce. And then this is obviously a state strategy for prenatal care, which does include group prenatal care, compensation and screening for connecting programs. It's a little different than what's recommended in the United States, but this is more recent recommendations. On a national level, these are 2 big policies that are going forward. So the Mommy's Act extended Medicaid coverage to year-long following childbirth. It also wants to increase Medicaid minimum reimbursement rates for maternal and OB services for people in underserved areas like New Mexico, and I'm sure like where you guys are working too. Part of the reason these maternity care healthcare deserts are popping up is the reimbursement for Medicaid is really poor. So like New Mexico, our reimbursement for birth services, if we get the global fee, is about $2,000. Not that we get it all, but that's the amount. The cost of out of birth experience or a birth center could be anywhere from $8,000 to $15,000 for one family. So the Medicaid reimbursement doesn't even really cover that cost completely. So if you think about our tertiary hospitals who are closing their labor and delivery, if their population they're serving is low income and Medicaid only, then they're going broke trying to keep their delivery services open, and that's part of why they're closing. So this Medicaid reimbursement rate increasing is really vital to keeping our hospital OBs open, as well as to be sustainable as a birth center, even a home birth midwife, because right, it's not enough. The Omnibus Act is also a big one. I guess they call it the Omnibus because it is actually a package of 13 bills addressed at meeting the needs of Black mothers and birthing people. So one of the recommendations is dedicated funding for community-based doulas and perinatal health workforce. I'm listing these policies because you're seeing policy recommendations come down from the United Nations. So that's a global, right? And then our national, which is the White House. And then you have these, and then these like Mommy's Act and Omnibus. And then there's the state recommendations that are coming down for improving maternal health. However, we're not seeing a huge change in our community, and maybe because these are new things, maybe we'll see a change in a couple of years, but we still have an issue with access. We're still having an issue with cost of care being out of proportion for what's needed and necessary in our communities. And our families are still left having to drive long distance for care or wait a long time to get into care. So like, what's the solution, right? It's kind of in our hands now to be like, what are we gonna do knowing all this information about our own communities and what's happening on a global and national and state level on a very slow way. So like, what can we do about it? I'm just going to touch on regenerative design because I have found in my own process of designing CWI through the years, this has made a lot of sense to me. And I didn't have the language until more recently to describe what I've done and how I've done it. regenerative social design is really something really close to me, because basically it talks about the social makeup of our groups that we work in, right? So we have these emotions, and we work together, and sometimes these emotions and patterns affect the outcomes of our work. And so the regenerative social design basically says you have to be aware of your own mental and behavioral patterns if you're going to make some real changes, not just in your community, but in your working environments. And we have to be really committed to integrate the parts of ourselves that were severed or wounded. So like working through those wounds or healing, leaving our comfortable nest and taking risks that increase our competencies, and then cultivating our capacity to lead and make change in the wider world. So these are some of behavioral changes that really should be happening on a personal level, because what happens is if we're not healing and have an awareness about our own behavior patterns, we end up creating the same oppressive dynamics in the systems that we're trying to transform. And then we end up having a system that just looks like the others. And then we wonder why it's not working. I'm really big on personal healing and doing the work within ourselves. I say this because in my own self, in my own journey, like Erin was talking about, I've done a lot of healing in my own way, because like many midwives, we were the care providers in our families, and in a lot of ways, sometimes we don't have the best boundaries when it comes to saying no, even in regards to like who we allow into our spaces, what kind of relationships we engage in. We tend to overwork, and there's some sort of feedback about this overworking. And it's really interesting because what happens is you create an environment for yourself where you are only valued by what you produce. You're only valued by being a caregiver and taking care of people. And so imagine when you become aware of that dynamic with yourself, like how your environments change. And then you think about the environment that you work in, and like how that changes when you become aware of these things. Just imagine everybody becoming aware of these things. So the best I can describe and explain this regenerative process for myself is this implementation, right? Initially, I had this idea to start Changing Women, and I was reflecting on how that was going to look. And I was creating and developing, analyzing my purpose, the content that was created. Like this circle really should be in relationship with each other. There's always integration and reflection. And this is just really more of a physical representation or demonstration, like a example of like my own process of grading CWI, and like how there was this reflective integrative process every time something new popped up or I created a new process within the organization. You don't have to memorize this. It's just more of like, this is a diagram of my process. So I want to get into the case study of Changing Women as this example of my intervention for the issue I saw in my community. So Changing Women, right, our mission is to empower our diverse Indigenous communities to protect cultural birth resiliency and the fundamental Indigenous human right to reproductive health, dignity, and justice. We just changed our mission this past year because cultural birth has already been in our community. Like, I'm not creating anything. We're supporting what's already there. We know they're resilient because it's still there and sustainable. There are some policy challenges to keep it safe and occurring in our community, but we're committed to maintaining that resiliency in our community. And we acknowledge that birth right now for all women is not supported through justice and isn't always full of dignity or support, like in a good way. So we wanted a mission that would support these things in our community. Some things to know is this picture here we're located in Albuquerque. We provide service to all of this area in Albuquerque, Santa Fe, and then to the east of us, where is Gallup, which is more rural. Fort Defiance on that side is the Navajo Nation. There are 23 federally recognized tribes in New Mexico, and a lot of them are either north or south of Albuquerque and then east. So that's our service area because that's where the tribes are located. We really are focusing on providing affordable care and to increase access to Indigenous birth workforce, into Indigenous birth, and then to increase Indigenous birth workforce. So one of the things that I didn't mention is when I started this work, there was like 20 Native American nurse midwives in the whole United States. I think there's more now. There's probably more, like 30 or 35. Those are nurse midwives. When it comes to licensed and certified professional, there's even less. I want to say maybe there's 3 or 4. There's not a whole lot of us. So we're really wanting to create a workforce that look like us, because there's information that supports that Native communities, Native women feel more supported when our healthcare team looks like them. We wanted to see how Indigenous birth ceremony would improve health of Indigenous birthing families. So reintegrating traditional birthing practices like birthing in a hogan and using traditional medicines to support the birth and the pregnancy before and after, like reintegrating some of these things that are already in our community, but like really making a focus to make it part of our care. And then supporting Native Indigenous families in navigating complex healthcare systems. I briefly touched on IHS providing service and care. The Indian Health Services has a mandate, like I said, to provide prenatal care and birth services, healthcare for all Native people who are federally enrolled, who are federally recognized. I'm a federally recognized Native American. I have papers to show that I am. So because of those papers, I can access care through IHS and get my needs met, supposedly. The challenge with that is the Indian Health Services usually are located on a reservation or in a service area. So because I'm Navajo, I'm from the Farmington area. If you look at the map, it's way up in the corner. My service area is Shiprock, New Mexico. So if I needed surgery, if I needed any higher level medical care other than normal clinic walk-in type thing, I would have to travel the 3 hours back to my service unit to get that. So imagine if you're a Native woman who's from Alaska, from Nebraska, from other states, and maybe they're married to their partner who they moved to Albuquerque, and IHS is supposed to provide care for them to get prenatal care, but they're out of their service unit. So where do they go? Because New Mexico has expanded our Medicaid, meaning more people are eligible for Medicaid, and a lot of our Native women are eligible for Medicaid, they get signed up and then they can go someplace else for care prenatally. But there is an Indian Health Service unit in Santa Fe that still provides prenatal care. They just don't do birth. So imagine being a new person to a community, you're Native American, where I go for care, I'm pregnant, I don't have insurance because I got all my care at IHS. How do I get care if there's no IHS close by? So that's part of the navigation issue when I say complex, because it's like, where do I get signed up for Medicaid? Am I eligible for Medicaid? I'm off my reservation. I want midwifery care. I want a home birth. She doesn't provide coverage for Native people because either she doesn't take Medicaid reimbursement. It's a hassle to get through. So I guess I just hold on and not get care for now until I absolutely need it. And that's what happens a lot of times, is they have a hard time navigating about where to go. My own personal story, I moved to Albuquerque a couple of years ago, and I was married to someone in the Pueblo of San Ildefonso, which is an hour and a half north from here. And I'm away from my service area. And when I moved to Albuquerque, I don't have insurance. So I had to figure out where to go for my care. And even though I'm not pregnant and I needed well woman care and just primary care support, is where do I go? And so I was in the same predicament a lot of our families are in when they come here. And I can imagine other places, they deal with the same issue. So that's why Changing Woman was created, right? There's healthcare deserts. There's these policy changes that are not happening fast enough. We know that these women are coming into the urban settings, or if they're in the rural setting, where do they go for care? And it's important to know that even though we have a healthcare model that has a intention of a home birth or in the process of building a birth center, like our goal isn't always a home birth. And that's where it's different from other care models like the birth center model and the home birth model. Really, the families that we see have issues accessing care, navigating the system. They also have multiple different kinds of health issues, lots of trauma. So we're really there to just support and advocate and encourage them to have the birth wherever they can. So whether it's a hospital or in this birthing suite picture, this is a birthing suite we don't quite have a birth center, we have a birth room. So if somebody has to travel 3 hours in from the reservation, they can go here and have their birth and then go home. This picture down at the bottom, the traditional Hogan birth, not every family has access to their traditional birthing grounds. Not everybody has a Hogan. And also families are still in the process of transitioning between learning about traditional birth and having the resources to have a traditional Hogan birth. And what I mean by that is having a Hogan, right? Not everyone has one. If you have a medicine person that they have access to support their birth, not everybody has that, some do. Also the planning for having a Hogan birth takes time. You see there's dirt at the bottom. This is a very beautiful setup. Not everybody setup is like this. There's no electricity, there's no running water in these locations. And so there's a lot of planning around traveling to the Hogan because Navajo Nation has dirt roads, they're muddy. There can be bad weather that can delay us. And so there's a lot of like planning, even this fireplace, like who's gonna keep the fire and the wood and that sort of thing. Where's mom and baby gonna recover? So there's a lot of planning that we do with people who want a traditional Hogan birth because it doesn't happen quickly. So we're really in a place of providing co-care and collaboration wherever the safest place for them to have birth. If you remember the map I showed you, we cover a large area. So it can be to drive to Gallup, New Mexico, it's like 2 hours. If we drive to Fort Defiance, an hour and a half. And so we've had to actually limit like traveling beyond Fort Defiance and Gallup because that can be a 3-hour time difference. And sometimes we don't get to the birth fast enough. But if you think about this wide circumference of 3 hours around our Albuquerque location and serving that wide area, that also means we interface with 5 different hospitals. There's 3 here in New Mexico, in Albuquerque, that we work primarily with. And then if we serve clients in Santa Fe, there's a hospital there. We serve families in Gallup, there's a hospital there. And then Fort Defiance, there's a hospital there. And so we have to be really clear about where people are birthing. If there's complications through their pregnancy that show up, that we transfer them efficiently and with good support. So a lot of times, because we're serving a specific population who are sometimes unwell, and maybe they start care well, and then as the things progress, they become unwell. So like diabetes, hypertension, preeclampsia, those are like really common top 3 things we transfer during pregnancy to a tertiary clinic because they can't birth at home with those things. And I say this because talking about the other models, the home birth model and the birth center model, right? They demonstrate success in birth center care and birth center births. And I'm not sure if their numbers are skewed, but their population of people who are Native American, Indigenous might be smaller. Our population that we serve 75 to, well, 80% is Native American, 80% is Medicaid insured. I wouldn't say like 50% of our moms are first-time moms, and then the other 50 are second and third time pregnant moms. So we do transfer a fair amount, which is why we have to change what our measures of success are, because it's not going to look like the other ones, right? So our measures of success are getting people into care early. I mentioned Native women don't access care often in the first trimester. So our measures of success are like all of our clients are going to get into care in the first trimester. The second piece is connecting birth families to needed resources. A lot of our families are low income. They have challenges navigating the system. And so like, do they have access to a medicine person or a social worker or somebody to do body work if they have trauma, if they need somebody to advocate for them. So we're really like focused on getting them access to those things. Supporting breastfeeding beyond 6 weeks also is a goal. We know Native women don't breastfeed sometimes after 6 weeks, so we're trying to support and increase the length of breastfeeding, knowing that this population of women, even though breastfeeding is really supported culturally, Native women tend to work in these jobs that don't support breastfeeding. So they work at Smith's, or they work at Walmart, or they work at the casino. And so these places don't have breastfeeding policies that support them. And so oftentimes they will end up stopping breastfeeding. It's really important for us to have positive collaborative relationships with multiple hospitals, because as you can see, we work with many. And so we have to have all their numbers to have, if there's a transfer that needs to happen, that they know we're coming. And then to do demonstrations with them about what we're doing and how we're doing it. We do make a plan with our pregnant moms who are choosing to birth further away from a hospital. In this picture, this woman birthed about 2 hours away from a hospital and a Hogan, and it was a successful Hogan birth. But that's not the case every time. And so we have to navigate like safety about how far away we'll attend births in a home setting or in a Hogan setting, if that's what they're wanting. And then really integrating nutrition and traditional medicine as part of care. So a lot of our families have food insecurity. They're obese, there's diabetes. They grew up in a community where chips and soda were easily accessible at the grocery store, but access to nutritious foods were not. A lot of Native families eat meat and potatoes, lots of potatoes, lots of fried potatoes. And so really bringing them back into like what a healthy diet looks like, what a healthy weight looks like, but not just the education, but then the barrier that comes with those who access WIC. What I found with WIC, even though it's a very helpful resource, is when people become pregnant, they have to show proof of pregnancy, and then they have to show where they're living. So a copy of their agreement with that they own their home or they rent their home, that sort of thing. So if they're homeless or they're living between homes or they're living with multiple family members, how do you show who owns it? Right, that's a barrier. If you're dealing with somebody who has trauma or drug addiction and their stuff is kind of all over, it's really hard to get it all in one spot together to give to WIC so you can get access to food from them. So our whole point of our nutrition program is to make it more accessible. So we have a nutrition person who provides education. She shows them how to cook healthy meals, and then she works with the local farmers to get fresh produce to them every 2 weeks. So the family gets, sometimes it's meat and vegetables, sometimes it's meat, vegetables, and honey, or sometimes it's milk. Like she has a blend of things that she gives to our families, but there's a specific budget for food for them. We don't give them a gift card because they can buy whatever unhealthy thing at the store. So the point is to connect them with healthy traditional foods from our community. And that's why she navigates a lot of procuring the food for our families. And then we do a distribution every time they come to appointments. So speaking a little bit about our program focus, right? I talked about our midwifery care that we provide through home birth, hospital co-care, We also have a community engagement piece. So this part is more about education and creating connections with the community. Some of the areas that we serve, there's no doulas there, there's no lactation consultants there, there's no midwives. They have to travel 30 minutes or longer to get to the doctor or to a medical care facility. And so part of the community engagement is to create resources in the community so that people can be trained as doulas and trained as lactation consultants. And then they can, or trained as peer counselor lactation is who they are. And then they stay in those communities and they provide support for the families that are living there. And then they become a support for us that we can use for the families that live in that area. And so the whole point of the community engagement is that piece is providing skills and knowledge and support to these individuals who live further away so they can become a resource in their community. And so there's that piece. Community engagement also means working with other organizations around healthcare, like education, and other intersectional issues, right? There's lots of that in midwifery around the missing murdered Indigenous women issue, the abuse that Native women experience through pregnancy and childbirth sometimes, homelessness, like that's an issue, access to clean water and land, that's an issue. And so community engagement is really creating partnerships with communities with intersectional issues that our clients deal with, and that's really her role. The part that I've transitioned over to, I used to be the midwifery director who oversaw our midwifery services, and I've switched over to more of our policy work because another piece of this, right, we can provide the direct services, we can train our community, but who's advocating for policy changes that support some of this innovative work that we're doing in our communities? And so I've shifted to this because as you've seen me list from a national and global perspective, maternal health is becoming a merging problem and an issue that needs to be addressed. But there's such poor representation in the Native American spectrum doing this work. And so that's where I can bring what I'm seeing in community, what I'm hearing from our clients, some of the challenges in building the organization to these advocacy spaces to talk about how those decisions they're making are impacting those of us working on the ground. And so these are just some of the focus things that our policy work is aimed at in the coming years. And so we really do want expanding health access for Native American people through legislative and advocacy pathways. And we are just now starting to build relationships with tribes and federal and state and global partners. Part of the challenge with serving Native people is there's so many legal barriers, right? There's the tribal sovereignty that tribes function, that's like they're their own sovereign nation, and then there's the state, and then there's the federal, and then there's a global. So where in all of those stack of people do we advocate for the rights of Native American and Indigenous people that will actually get reinforced? Right, that's the challenge that I deal with all the time, because I was just at the UN, right, advocating for these things. We got these great policies, these recommendations that were implemented, and then now what? One of the challenges that I'm seeing on the ground is how are we enforcing these recommendations on a hospital level? We talk about equity and inclusion, we talk about racism, some of these things that affect our health in a different way. Like how are they enforcing hospitals to be accountable to these recommendations being made? That's my question. Because hospitals are kind of like their own policy infrastructure island, right? One hospital policy is not the same as the one next to it. Same with midwives, right? Some hospitals have midwives and some do not. And so like, how are we enforcing that midwifery is a pathway for healing and is good for our communities, but yet hospitals get to decide if they're going to work with midwives or not. So like, it doesn't quite line up. And so this is where our policy and advocacy work comes in hand, because then it's like I can speak to what's happening in our community and how these policies translate into action or not. And they need to hear that from us, because, oftentimes people don't know what's happening on the ground, and it's up to us to report these things and hopefully turn them into policy change. Oh, this is the slide that was a little funny. Okay, so a little interesting thing about Changing Woman is we were initially, when I started this work, I created a board of directors. I was doing the work of trying to decide, do we hire an ED? Am I the ED? Should we get a operations manager? Like, what do we need to function? And I did some research, didn't find some good models. There hasn't been other healthcare initiatives like my own out there. So like, how do we navigate what our leadership model is going to look like if nothing has been created like this before? And so we did a few years of trial and error, as best I could say. I, for a long time, was the executive director / program director. So initially, in the beginning, because we were building relationships with our funders, we did a storytelling project to demonstrate how women were affected and how they experienced navigating the healthcare system with their pregnancies. I believe there was 3 stories that were created. These women came and they created their own story, and we put them up in a hotel for like 4 days, and that's what they did. And so that was one of our first earlier projects. A second one was during the Standing Rock activities happening. I was really emotionally impacted by what was happening there, because most of what I was hearing was the harm that was being done to that Native community because they were protecting their water. And this was an interesting situation because many of the tribes came together to work on providing safety and allyship to keep the water safe in Standing Rock. And what I saw there was like half of the population were women and children, but where do they go for care? So this idea of like, we should set up a field clinic at Standing Rock. And so I did an online fundraising to get money, supplies, and I actually worked with 3 midwives. One of the midwives was on my board. She came with me, and then 2 were CPMs. One was an unlicensed midwife and the other was a CPM, both Indigenous. And we all drove up to Standing Rock to set up a field clinic. And I believe that was in October, and that field clinic stayed there through January before everything closed and shut down because of weather. And that was one of our earlier projects. I'm giving this background because if I was the only director and then we had board members, getting in some funding and having very directed projects to focus on. As we grew and my project objectives became more programmatic focused areas, so like the direct services, the education, and then the policy, those became more evolved over the years. And as this emerging issue of healthcare deserts started to show up, the question still is a birth center a viable way to address it? Because people still have to drive here for care, and that's still a problem. I know that home birth midwives, that LMs and the CPMs provide wonderful care in a home setting, and they're trained to provide care in a home setting with low resources on purpose. And so we are not engaging them in a way that to their best of their abilities, basically because we're still pretty beholden to this having people come in for care situation. And so that was one of the evolutional thoughts that I had in this process of creating CWI, was like, how do we get care to the people and who's best suited to do that work? And of course, through the years, we had lots of challenges because you have people that come in who appear to have all these skill sets and all this knowledge, and they're going to do all these things. And then you find out later that they were not doing what they were supposed to be doing, or maybe they weren't well fitted for the work that you were trying to do. And I have to say, in the last 8 years, I've done lots of, I've worked with a lot of different people, and realizing they weren't quite fitted well as a teammate, as well as someone to co-create a new model. Because what happens is you get people who've been maybe doing nonprofit work for a long time, and they're used to it working a certain way, and so they just know how to recreate that way. What I needed on my board and in my staff is people who knew nonprofit work and like some of the documents that needed to be created, but also were open to being innovative and maybe navigating away from a hierarchy system of decision making and leadership, and being more in a position of shared power. And you often hear, I hear this all the time from different coalitions, like they want shared power, they want the power, they want Black, Indigenous folks in position of power. But there's still a lot of work to be done around our understanding of power. And unfortunately, a lot of our nonprofits still reflect a hierarchy of power. So there's a board, there's an ED, or there's one person making all the decisions, or is responsible for the health of their team and integrating these programs. And it's an immeasurable amount of work for one person to do, and one person can do that. That's why we get so many EDs burning out. So many of us midwives are leaving because like we've been doing all this work and it's unrealistic. And so part of our transition actually in the last 2 years is to go to this leadership model that is decentralized. When I say decentralized, that means the board of directors and the directors of our programming, there's 4 of us. We actually work together to support and move the mission forward. So I know there's some policies around financial things that the nonprofit has to manage, and that's the board's work. But in regards to like integrating policies that reflect shared power, shared decision-making, like we get to decide how that looks. And so that's why we've shifted to that way, because the work that we're doing is immense. It's impossible for one person to do. And also, if we're going to demand change in our community and in our organizations that reflect shared leadership and shared power, then the policies that we create in our new forming organizations also have to reflect that. And that's the piece that is really important to me with Changing Women, is that our policies in regards to our staff and to our board reflect what we share in the community around shared power and shared leadership. And also, if we're pushing for length of time of leave for postpartum recovery, like our policies have to reflect that. If we're pushing for flexible work schedules, our policies have to reflect that. If we don't want to have a super hyper powered overworking organization, because some places are like that, like the expectation is you're going to produce and be productive and your value is based on your productivity, then we have to create a different system within our org that says you are valued whether you're productive or not, but like there's some flexibility in your work schedule and work location, and that you get an amount of time off to do your personal life stuff so that you can be productive or helpful within the organization. So I would say the majority of our staff is Native American, Indigenous. And so what you should know about those of us who are Native American is we're pretty involved in our community. So if we are participating in like ceremonies or Pueblo feast days, there's things in our community that require us to be there. So if we're moms and we're family members, then we have to be able to create policies that reflect that we support them. So some of the challenges I want to talk about that we face getting here are I'm going to be open. Like, I had some very unaware things about myself and how it affected my ability to work with team. I'm just going to say I'm a people pleaser. I was the caretaker of my family. I didn't have good boundaries. I thought everybody had the same intentions as I did in regards to the work that we were going to do together. Unfortunately, that created the worst dynamics, because then I wasn't able to hold people accountable for what they weren't doing. I invited the wrong people to work with me. And so once I was able to understand my part in this and have better boundaries and be accountable and actually enforce accountability, things really changed within my working dynamic. Founding board members are pretty unaware of the differences between a working board and an established board. You create a board and you want skills, you want people who are knowledgeable about this work, but so often we're unaware of how much work that is and what a founding board does. Like, they create a lot of documents. They're a working board. They should be meeting every month to get all these foundational documents created, because their job is governance and financial accountability. They have a workload that's different from those of us working on the operations side. And so oftentimes boards, the beginning boards, are unaware of the work that is required. And so this definitely was a challenge for us. We've had, I think I've had like 5 or 6 boards at this point. The first couple of boards were very challenging for me, because there just was a lack of clarity on what they were supposed to be doing and who was supposed to be doing it. And there were still old paradigms of governing that many were used to and were not prepared to step into a new way of doing things. There's also just really interesting power dynamics that happen between board and founder. As a founder, there's an assumed power that I have, right? People respect what I do, people respect what I have to offer, but I'm still an employee of the organization. And so if I'm not at the top, or if that's what our leadership model looks like, I have to do what other people tell me. I could still lose my job. And there's definitely lots of history of founders being kicked out of their organization when paradigm shifts happened with new leadership and new board members. And so it creates these really odd dynamics in an organization. And oftentimes people leave, board members can leave, or the founder can leave because of these power dynamics that are at play. Another big one that's been really challenging for us is community gossip. Like I said, I've had the challenge of working with the wrong people. I've had a lot of wrong people experience that I've worked with, and I've had to make some hard decisions about them needing to go. And so that creates odd dynamics in the community, because people want to know, like, why did that person leave and what's happening over there. We've gotten a lot of attention because of our mission and our model and being new. So obviously there's lots of eyes that we can't fail, or we have to look a certain way. And unfortunately, there is people who don't wish good things for us for us to succeed. So there's all those really interesting dynamics that actually make it harder to do our work. And I attribute that to trauma in our communities, because I feel like as Native people, we're used to failure, we're prepared for failure. And there's just interesting things that happen when those who try to make a difference, either get to a point where they just get cut down by the knees by community and people that they worked with initially. And so that's something that I'm honest about as part of our process, and something we've had to grow out of. What we've really learned in the last year and last couple of years is that if we support personal health practices in our staff, in our relationships, meaning like we understand people need to take time off, need to take care of their families, people come back prepared and ready to work, and they feel more supported. Really important to have an active board involved when you're starting out. We still have a very active board. They meet once a month. We meet from 6 sometimes to 11 p.m. That's a couple hours once a month. So really needing a board that's involved, but not micromanaging of the team. And that's kind of a balance we have to walk, because we want to work as a team, but the board doesn't need to approve every little thing in the organization, and that's on the operations side. And that's where I mean about having clarity about who's doing what. It's really important to hire the right people. So I want to talk about the culture of organizations, right? We've all worked in different places. Some cultures in our work settings are very focused on productivity. You got to be really busy. You got to do all this work. Failure can also be shamed and blamed. Like there can be that kind of environment that's set up depending on where you work. And what I found is, like, if you're going to shift the culture of where you're working, you really got to hire the right people. Recently, we hired an executive director who did a terrible job. Like, it was really hard. She really did a terrible job and created a lot of turmoil within our organization and within the community, and that we had to really address when she left. And so we really want to hire people who are driven and compassionate. Creating infrastructure that is informed by the impact of bidirectional trauma supports compassion care for staff and clients. What I mean by that is, when you're in a community taking care of people who are experiencing trauma, when I say trauma, like physical abuse, food insecurity, families that are not supportive, having issues to accessing vehicles, that can be a lot for your heart. And sometimes these structures are in the community and they can pit us against each other. And then we have to come back to our organizations. And so how do our organizations take care of us who are doing this work on the front lines every day? And you do that by having access to traditional medicine. At least for us, that's what we do. Flexible work schedules. People can bring their families to work with their kids. They can leave early to go pick up kids and bring them home. To the office if they need to. Like, there's a lot of infrastructure that supports those of us who are experiencing trauma or have had a traumatic experience in the community. And that's something that's important, because we don't want to base our relationship on transactions or based off of productivity. We want to show that we care about our staff and we care about each other, and we know that the work we're doing is tough. I think it's really important to have mutual respect for shared decision making, and it makes a very powerful team, which is why we shifted to this decentralized model, because there's shared decision making. This lift that we're doing isn't just one person, it's everybody, and everybody's accountable to each other. But really respecting each other's perspective, what they have to offer, what they have to bring, and also understanding everybody's capacity is going to look different every day. I think we assume that everybody's like 100% ready to go every day, but it's like our Native families, even those that I work with, have stuff happening in their family. Somebody's died, there's stuff going on in their community. There's a ceremony they're at, maybe their kid got in trouble. There's all of these personal dynamics that affect our output. And so having mutual respect is saying, I respect what you're offering today, knowing that there's this backdrop of things that are happening, but I'm not going to shame and blame you if you're not showing up 100%. I think that's important. And then the last piece is that having rest time and downtime is super vital to moral team dynamics and understanding how important our families are to our personal productivity. Because we can't just work, right? We need to take care of ourselves. We know we have to take care of our families. So when people have adequate time to rest, like right now, my midwifery director's off for 2 weeks. Granted, she's been on for 2 months on call because our other midwife is out sick. But there's a balance, right, that we're trying to create so that people don't get burned out and that they're supported with the work that they're doing within our organization. So these are just some things that I've learned since I've created CWI and have supported CWI. There's so much more, right? This is evolving, our organization's evolving and growing. What I told Erin is I'm actually shifting out of being the founder, working for CWI in this capacity as the health policy director, and I'm shifting over to doing some of my own work on a business side of things. Partially because, again, the founder, there can be power dynamics. I'm not leaving because of the power dynamics. Both basically, I want there to be equilibrium of power sharing, and I have to be out of that for that to happen. Secondly, there's this really interesting thing that happens between the organization you create and your own personal development and your growth. They go hand in hand. So I've given so much to CWI that there's some skills and knowledge that I've actually not been able to pursue on a personal level because I've been so committed to my organization, and it's time for me to grow. And so there's some other things that I'm interested in and want to develop, but will still support the organization in a different capacity. And as next year comes, but that's something I think people don't always talk about, is like the founder and the organization they found. Like it's like this living, it is like this living being. Like I just birthed this baby, and now I'm handing my baby off to co-parents that they're gonna now decide what to do next. And I've just done all this work to find the right co-parents, right, and the right parenting model to do this work in a good way. But that's what I've been doing for 8 years, and that's what I've learned, and how we're going to address these issues that I mentioned in our community through this care model that's been created. So I just want to end with, like, it's not impossible to do this work. Like, obviously, I've dedicated so many years of my life to this. It hasn't been easy, but I believe if we dream it up and we have a solid plan and we know who we want to work with, like, it is possible to create a decentralized model intervention to address some of our issues in our community that isn't always attached to a hospital or to a university. Like, that helps. They're part of the team. It supports what we're doing. But a lot of times, like, these things that I've been wanting to implement would have been really challenging to do in a hospital setting. And that's why I had to go out and do it in a different way. And so, yeah, I just want to iterate that it's not impossible. So if you guys are dreaming of creating a model, an intervention, an organization to carry out some work that's not being addressed in your community, like, it is possible to do it. I'm happy to help you. That's kind of what I want to do in my afterlife work, is to help those who have a dream or a vision to implement in their community. And, like, I'm happy to support that because I have all these years of experience of doing that already. And so these are just some resources. The Regenerative Design as a Chain Maker book is really helpful. If you want to look at this maternal health policy change, the Center for Reproductive Rights has an outline of that. And there's some information about structural racism. So that's the end of my presentation. I went over by 18 minutes. I don't know if people have questions. I feel like I talked a long time. Does anyone have questions for me?
Nicole, while people are getting a chance to collect themselves and maybe put something in the chat, thank you so much. Are you willing to take a question or two if they come up? Just noting the time. Okay. Yeah, what an incredibly rich, insightful, inspiring presentation. Thanks for giving us an inside look into these years of work and the evolution. I know I've been following you for many years, so it's just exciting to hear the backdrop and more of the details. There is so much wisdom there.
Yeah, it's a lot. It's a lot of information, and it's like, oh, there's so many things that I did in 8 years. And I didn't talk about, like, there is grief too, right? Mm-hmm. There's grief in the relationships that didn't work out. Like, there's a lot of people that I lost along the way. Like, I got divorced, I had to move into another city to support this work. Some of these early partners that I had, some of them I don't have relationships with anymore for different reasons. And also, like, the incredible growth that I went through as a founder to do this work means like I'm a completely different person than when I started this work. And so what happens is, as the landscape has shifted for maternal health care in this organization, my own ecosystem of support has shifted completely. Like, I don't have the same partnerships that I had at some of the attachments. Some of the early folks that I connected with, they're off doing their awesome work. And it doesn't mean I don't support them anymore. It's just like we've all gone in our own directions. And yeah, I think there's definitely grief with letting go of some of these relationships that don't serve me anymore, especially as I've evolved and healed my trauma and have become more clear about my mission in the world and who I really want to be around. Like, that's the piece. That's another part of this that's super exciting, is like, I'm shifting out of this organization because I want to collaborate with innovators and thought leaders globally to address some of these issues in their communities. And I have some wisdom and experience now that I can support others doing this work at the very early stages in their community. And like, I don't have to do this work the way I've been doing it. And it feels good to hand it off. It also feels very powerful as a leader to say that it's not just me that has to do this work, that others can do it and I can hand it off in a healthy way without cutting anybody's off at the knees out of jealousy or whatever that often comes up, and unfortunately in our women's spaces. And so like, handing off the work to other leaders, I think, is vitally important.
Is it possible to ask a question without typing it in?
Please do. Yeah.
Nicole, I want to thank you so much for this presentation. Like, Erin, I've been following you for years and watching as Changing Women has evolved. And it's so helpful to have this language that you're bringing about regenerative social designs and to see your reflections over the years about how your organization has grown and how you're decentralizing. I'm trained as a CPM, and I'm founding an organization that is similar in design, a different focus because of my regional aspect. And now at Frontier as a CNM student, and that perpetuation of hustle culture is kind of foundational in healthcare, and certainly exists within out-of-hospital networks. And I'm wondering if you can speak a bit to how you cultivate an organization that shifts away from that kind of hard work, productivity culture, while also teaching people to like do different skills, right? Like you're talking about, teaching CNMs who may not have experience in out-of-hospital birth or community birth, and Indigenous birth. How do you cultivate and hire enough people to do that while also learning the skill?
Yeah. So on the side of the hustle culture piece, I have found as a leader in my organization that I have to demonstrate these things. If people don't see me taking time off, if people don't see me taking care of myself, eating my lunch, then they're going to feel like they can't either. So you have to demonstrate this as a leader in your organization, especially when you work in a group, because people have their assumptions when you don't talk. So some of the assumptions people could have, because they have their trauma, right? And you come to work and you're not talking to people and you're tired and people are like, oh my gosh, is she mad at me? She's not talking, right? So I've learned that I come to work and I'm like, I'm not mad at anybody. I'm just really tired. And when I'm tired, I don't talk a lot. So just FYI. And then people are like, oh, okay, it's not me. And also, like, if people are working extra hard on projects, it's like, I'm reminding them, like, did you take time off? You should leave early. You just finished this, you should go home. And so my board also is like that with each other and with the staff. Like, if you worked hard, you should take some time off. So it's interesting. You can create these healthy policies, but people have to follow them, like implement, like use them. The other thing about this side of things is one of the questions I ask of people when we hire new folks is, what are your health practices outside of work? So like, are you in therapy? I mean, not everybody might disclose that, but like that to me is a good sign that they're working on their stuff. Do they have boundary issues? You know, are they in this like constantly work so much and they can't rest type of way? I want to know like what their practices are to maintain their balance and their wellness at home. And that to me is a sign of like how maybe they could be in the office setting. So there's that. But a lot of it you're going to have to mirror and demonstrate in your actions as a leader. And that's not always easy, but I find that because people watch you and they're going to say, oh, well, she's the founder, so she's taking a rest. So I better take a rest, you know? So there's that. The other thing you asked about training folks, right? We have a blended practice. I didn't talk about that. I'm a CNM. I work with an LM and then I work with a CPM. And the CPM and LM do majority of the birth service and care. And then of course I did some of the birth for a long time. And now I'm just doing the walk-in easy access clinic. And then I'm doing policy work. So we have a blended practice of skills already. But that's what we want. That was the design. That's who we need to take care of. So a lot of it is the forethought in your design process of like who you're going to take care of, who do you want to work with, how do you want to work with them. And I feel like sometimes people miss this piece in development about what their organizational design is going to do the work that's intended. I call it like creating your car. We all have different cars and you have a different driver. So what kind of car are you going to create? Because it's got to drive a long distance, but like you get to decide who's in it with you and how do you want to work together. Like think about it from that perspective. And obviously once you create it, people become attracted who want to work in this way with you. And we start to have that now. You do get people who need something from you. So one of the things that I had to learn not to do is I'm such a helper. Like I see people like who need help, like, oh, you need a job. Let me create a job for you. I don't have a lot of money, but I'm going to create this for you. Don't do that. You need to have a fully functioning organization to add people. And that's a learning for me is like, I can't help people if I'm still trying to create something. I don't have the capacity. The organization does not have the capacity to bring on somebody who's needs extra help and support. Like you need the right people who have the skills and the time to commit, and the communication skills, like that's so important. Like we don't, so much of our disagreements is lack of communication or poor communication or inability to communicate, or seeing communication through a trauma lens of like, you're talking to me and you're attacking me versus, no, I'm just being direct with you. Right. So like understanding that dynamic with people you work with, down to breaking down, like even responding to emails. It's really interesting. People get offended if you don't respond immediately. I got in trouble because I used caps in my email one time, but I really used it just to differentiate the topics. And my board president at the time was like, she's yelling at us. And I'm like, no, I wasn't. I was just trying to help you differentiate all of what I said. So you're not reading one blob of a paragraph. But it's funny, communication continues to be like super important. Even when you're working with like global teams, because I'm learning about this in my PhD, like how important trust and communication is in teamwork. And so like, how do we create that in our communities or this, like the things that we're creating? I don't know if I answered that question for you. Okay, great. So Kimberly asked, are there resources available for individuals who are not from the Indigenous community to learn about native birth customs? Not entirely. So I know Rhonda Grantham for Center for Indigenous Midwifery has some training and education. There's not a lot written about traditional birth practices. A lot of it, of what I've learned is orally through multiple people. I do talk a little bit about birth, traditional birth in what is it called? Indigenous Goddess Gang magazine. There's some information that I've provided on Navajo birth. I think if you're working with a Native community, it'd be good to ask clients, are there Native birthing customs they want to integrate into their experience? If they speak their native language, is there a way for us not to speak English the minute the baby's born so you can say hello to your baby in their native language? There's things like that you can do. Sometimes they won't share stuff with you because you're not Indigenous and they're afraid, or maybe you don't have time to have that dialogue. If they don't know, you might ask them to go to their community to ask if there are traditional birthing practices that they are aware of. They can ask their grandmother, their auntie, or someone, because then it requires them to go search for that information. And most people are motivated to do that, but you're just creating a dialogue so that they can go do that work. And then hopefully you can enforce it and support it in their birth settings. So there's that. Yeah, it's a little tricky to talk about birth traditions and ceremony because unfortunately, a lot of our customs can be appropriated. Like we see a lot of that in our midwifery spaces and in our other spaces, right? There's money to be made off of our customs. And so people can be hesitant to write it down and to share it because of that. So best just create a dialogue with families about what that looks like for them. Let's see, is there anything that you feel a non-native, non-Indigenous primary care provider should do as your number one thing to focus on if we're ever the chance to care for Indigenous mother? Yeah, that's a good question. I feel like Indigenous people function on a different timeline. We call it Indian time because we're always late. But if we have to integrate into a system that's pushing us through, you get I don't know how long you get with people, whether it's 15 minutes or 30. So how do you make a connection with somebody in that period of time? I feel like building trust with Indigenous people, Native people is so important. And so it could be asking about their family or how they're doing. I think that's a piece of building trust. I know it can be a little tricky as a non-Indigenous person to have a cultural conversation, right? Because I've heard that from people are like, what is my place? And asking about somebody else's customs. But because you're the provider and you're supposed to help facilitate this space, whether it's birth with them, then how do you have a conversation with them about what's vitally important to them? Some information to know is not every Native Indigenous person is immersed in their traditional way of living because of colonization. And so they are also relearning their customs. So they don't know everything. Part of your time with them, like I mentioned with Kimberly, is having a conversation so that they can begin to think about their birthing experience or their pregnancy as a ceremonial process. Well, for me, that's what I would call it, because in ceremony, we're preparing, right? We're having awareness that some healing is going to happen. There's discomfort that's going to happen, which is the birth. You're going to rely on your relatives to support you, which happens in a ceremony. And so a Native person who is immersed in their traditions are going to bring up their baby in a traditional system from their home community. So they're going to have a laugh ceremony maybe, or they're going to have their walk-in ceremony, or they're going to have their ceremonies that Indigenous people have to mark their growth of their child, to bring them up in an Indigenous way. And so again, not every family knows this. And so part of the questioning could be like, are there customs that you want to implement as part of your care that I should be aware of so I can support that? Like I gave one about the birth, right? About being able to give them space to welcome their baby in their native language. Like seems like an easy thing to do, but we forget that if we're bringing our child into this world in an Indigenous way, the first thing they should hear is their Indigenous language, welcoming them, right? That's beautiful. The other thing about it is when Native people are pregnant and they want to connect with their traditional roots and their traditional values, stories, and eating, they also don't know where to go for that. And so like, how do you support them asking these questions of their elders or their family? So like, again, it's putting it on them to go search for this information. And they might have to talk to a few people, but that would be helpful. I can't say there's one vital thing. I feel like it's trust building, good communication, and like having the time to get to know them, so that if there's enough trust built, you can have this conversation about traditional birth and how to support that. Oh, right. So CDBY is having an Indigenous Reproductive Health Policy Summit from November 13th through the 17th. It's a virtual summit. So I will be sharing, I'll probably share a flyer with Erin, and then she can share it with you all. But I wanted to focus on some of the policy challenges that Native American face accessing care, midwives who are Indigenous trying to provide care, what other people are doing in other countries, so like Canada for one, and how they're addressing improving maternal health through their Indigenous midwifery work. And it really is more of a policy focus, so it's for the whole week, but the virtual is probably like more like 1 or 2 panel discussions a day to talk about specific subjects. So one is I'm going to have the midwives and their representative from Hawaii talk about the licensure issue they're dealing with there and how it's affecting their family or their communities. Another discussion, someone's going to speak about the complexity of Indian Health Service, because people have so many questions like, what is IHS and why is it a problem? So you get a sense of the complexity of navigating the system and the funding and the challenges that those of us who have tribal enrollment have challenges around accessing care. I'm also going to have Hermine Hayes come and talk about rights around childbirth. So like if they're having a hospital birth or home birth, like what are the rights as a birthing person to have an informed, supported, dignity supported birth experience, and what happens when that doesn't happen, and what are their rights. So I'll send we're getting ready. We probably won't have our agenda till the end of the month, but we are going to have a discussion on abortion access for Native people on the 13th of this month, which I think we're going to have our flyer out tomorrow. So I'll share that with Erin. But yeah, thank you everybody for hanging in there with me for the hour and 40 minutes of my session. It's a lot to talk about.
Wow, thank you, Nicole. You're so incredibly generous with your knowledge, and the time you took to teach us and share your insights is a lot of work to share all that with us. And I think you've got a really passionate group of people here who really just have soaked up everything you shared. So thank you so much.
I know it's a little out there because it's like, who's going to start an organization? But there are a few people who might, like you. Is it Hattie? Yeah. It's a big lift, but it is worth it. I just think about the decision to do this work 11 years ago. I'm like, oh, what if I didn't do it? There would be no CWI. There would be nothing of everything we're doing now. It's amazing how one decision changes your life and the community's lives.
It's so inspiring. Thank you. Okay. Rest up, everyone. Thank you so much for joining us, and we'll keep sharing resources as they come out so we can support your work, Nicole.